Hi everyone, I am Dr. Sumit Jain from Department of Orthopedics. Today we will be doing the solutions of subject wise test orthopedics starting from question 131 onwards. So the first question is the question number 131 is, what is the name of this clinical finding that can be seen in rickets? I presume the most common deformity which you can see here in this picture is around the knee joints. Okay, and although all these deformities whatever they have mentioned could be there, could be seen in rickets. A patient can have cubitus varus and valgus deformities, but for that we need to have we need to see the forearms in full extension. You cannot comment on the cubitus varus or valgus deformity when the elbows are flexed. Double malleoli definitely can be seen because of broadening of the physis, but that is also not very clearly seen in this picture. Another deformity is windswept deformity. If we have a look at this picture, there you will see a varus deformity in one knee and valgus deformity in another knee. Essentially this deformity is known as windswept deformity, as if wind is sweeping away the legs in one direction. That is why this deformity is called windswept deformity. So the answer for this question is going to be C, the windswept deformity. Okay. So let us move on to question number 132. They have shown a picture and the fracture shown on this X-ray is known as. Now if you see this is the lower end of the radius and this is the lower end of the ulna, and fracture line is going somewhere like this. Okay, and in lateral X-ray you will see there is no movement of the distal fragment either on the volar side or on the dorsal side. If the fracture occurs at the cortico-cancellous junction, this is the cortex, if you see it is thinning down, now it is becoming the cancellous bone. Similarly here it is thinning down, becoming cancellous bone. If fracture happens somewhere in this region, that is called distal and radius fracture. Now depending on that, if it could either displace on the volar side or it can displace on the dorsal side. If it displaces on the dorsal side, it is called Cooley's fracture. If it displaces on the volar side, this is called Smith's fracture. Okay, so we can't see any movement on the dorsal or volar aspect on the lateral X-rays. So question A, answer A and B are out. So another thing is volar Barton fracture they have mentioned. Volar Barton fracture is the coronal fracture of the distal radii, which happens somewhere like this, where the distal fragment, this fragment get displaced on the volar side along with subluxation and dislocation of the carpal bones. But in this case you can see the carpal bones are nicely situated in the fossa of the distal radius. So this is not even a volar Barton fracture. So this fracture is something else which is not the choices which is not given here. So the answer will go with is the none of the above. Now the question is, what is this fracture? Now if you have a look at this fracture, this is the fracture of the radial styloid process, and the fracture of the radial styloid process is known as Schoffer's fracture. So the answer for this question is going to be D, none of the above. Okay, so let us move on to question number 133. Which of the following is not a intramedullary nail? So first choice is SP nail. We don't commonly use SP nail nowadays, but what it is we'll see in the next slide. Kuncher's nail or K nail, we all know it is used for fixation of shaft femur fractures, and we put it into the shaft of the femur in the intramedullary cavity. So yes, this is the intramedullary nail. Titanium elastic nails are used to fix the long bones in pediatric population. So yes, we use them to put inside the medullary canal, so they are also intramedullary nail. Square nail is something which was used earlier for the fixation of shaft radius and ulna fractures. Shaft radius and ulna fracture. So this is again a intramedullary nail. Now SP nail, which is also known as Smith-Peterson nail, was used in previously for fixation of the hip fractures. Now if you see, it has got two parts. One is this SP nail, and there is another SP nail with plate. This McLaughlin plate is there. So this was used to fix the intertrochanteric or neck femur fracture. Now you can see this nail is not being put into the medullary cavity or medullary canal of this bone. So that's why this is not a intramedullary device or nail. So the answer of this question is going to be SP nail, A. A is the answer to the question number 133. Okay. So the next question is 134. A 34-year-old female was operated for fractured radial neck. So she underwent surgery around the elbow, and post-operatively she was unable to extend her fingers at metacarpophalangeal joints. There was no sensory loss in the hand. Which nerve is most commonly injured? We all know that radial nerve is most commonly injured around the fractures of the humerus. Okay, but in this case the surgery is being done below the shaft of the humerus around the elbow, and if radial nerve goes, definitely will have loss of extension of the metacarpophalangeal joints, but will have sensory loss as well if the radial nerve is injured. And so if we see, the radial nerve around the elbow divides into two nerves. One is the posterior interosseous nerve, other is the superficial radial nerve. So the superficial radial nerve is purely sensory nerve, which gives the sensation over the first Bep space, and the posterior interosseous nerve is responsible for causing extension at the metacarpophalangeal joints and at the interphalangeal joints. As there is no sensory loss and posterior interosseous nerve is most commonly injured in the surgeries or injuries around the elbow joint. So the answer to this question is going to be posterior interosseous nerve. The choice B is going to be the answer. Okay. So the question next 135 is, what is the earliest bony changes of osteomyelitis on X-rays? So they are asking specifically what changes you will see in the bones, okay, not in the soft tissues, on X-rays. Okay, so loss of soft tissue planes, yes, this is the first change which you will see on the X-rays, but this is not a bony change. This is not a bony change. This is soft tissue change. Okay, so they are asking about the bony changes. Okay, periosteal reaction is something which occurs, which is the first bony change you will see on the X-rays, which happens around 7 to 10 days after the osteomyelitis has set in. Okay, sequestrum is something which you will see later on when all the bone has been damaged and the bone has become dead. Okay, the lytic defects are again seen in the chronic osteomyelitis stages. Okay, so the periosteal reaction is going to be the answer to this question, because in pyogenic osteomyelitis, X-ray in the first 24 to 48 hours will show loss of the soft tissue planes. Okay, this is the earliest change on X-ray, but this is not the earliest bony change on X-ray. The earliest bony change on X-ray is the periosteal reaction, which usually can be seen from 7 to 10 days. So the answer of question number 135 is going to be B, periosteal reaction. Next question 136 is, which of the following is true regarding the acute pyogenic osteomyelitis? Okay, so we all know most common area involved in osteomyelitis is metaphysis. Okay, so he is asking most common site involved is diaphysis, so this is not true. Okay, so sequestrum is the new bone formation surrounding the involucrum. This is not the right statement. Basically, involucrum is something which surrounds the sequestrum. Okay, involucrum surrounds sequestrum. So, involucrum is the new bone formation around the dead bone. So, this is also not the true statement. The third statement is most common mode of infection is the direct inoculation to the trauma due to trauma. So, the most common cause for osteomyelitis is hematogenous spread. Okay, so this statement is also wrong. Cloacas are discharging sinuses. This is something which you will see in the chronic osteomyelitis. So, once the new bone will be formed, so let us say this is the sequestrum, okay, and this is the new bone formed around that, which is called involucrum. So, this is involucrum and this is the dead piece of bone which is lying inside, which is sequestrum. So, whatever pus will be there around this area, that will be discharged through a hole in the involucrum. Okay, that hole in the involucrum is called cloaca. So, D is the right answer to this question number 136. Okay. So, the question number 137, the most common organism causing osteomyelitis in drug abusers is. So, we all know the most common organism which causes osteomyelitis is Staphylococcus aureus. Okay, but in this case he has specifically asked the drug abusers. Okay, so IV drug abusers who keep on taking the drugs through the IV routes, they are most commonly having osteomyelitis due to the organism called Pseudomonas. Okay, so the answer to the question number 137 is going to be Pseudomonas. Pseudomonas is also a common organism in patients suffering from sickle cell disease. So, IV drug abusers and sickle cell disease patients, they have osteomyelitis mainly due to Pseudomonas. So, answer to the question number 137 is D. Next question 138, Tom Smith arthritis is infectious arthritis destroying. So, Tom Smith arthritis is septic arthritis of the hip in infancy. Okay, as we know, the femoral head has got very precarious blood supply. Okay, so the capital femoral epiphysis, it receives its blood supply from the obturator artery through the fovea centralis and the physeal arteries or retinacular arteries. Okay, so if the pus builds up in the hip joint, so the pressure inside will increase and that will damage the blood supply of the capital femoral epiphysis. Okay, so the most commonly the area which is destroyed is capital femoral epiphysis. So, the answer to this question is D, the capital femoral epiphysis. Rest of the areas, neck, femur, acetabulum roof, they are destroyed later on. The earliest, the most commonly injured area is capital femoral epiphysis. So, the next question is, an 8-year-old child is suffering from transient synovitis of the hip joint. Which of the following statement is false? So, transient synovitis of the hip is something which usually follows some sort of upper respiratory tract infection, whether it is bacterial or viral. So, the bacteria or virus, they cross react and causes the synovitis in the hip joint, and so they are asking which of the following statement is false. So, once the patient develops synovitis, all the features are usually the same. Okay, so this may follow the upper respiratory tract infection. Yes, that is a true statement, but for our this question, because we are trying to find out the false statement, this is not the answer. So, WBC count and ESR are usually normal, and if you see somebody is having upper respiratory tract infection, and usually the WBC count in viral infection is going to be normal. Okay, so this is also the right statement, but this is not true as far as this question is concerned. So, the hip is typically held in adduction and internal rotation. We all know whenever we have synovitis or fluid inside the hip joint, our hip joint will try to accommodate the fluid by creating the maximum space, which can be done if the hip goes into flexion and abduction and external rotation. Okay. So, if the hip goes into abduction and external rotation, that is that creates the maximum space to accommodate fluid. Okay. So, this is a false statement, and this is true for our this question, okay, because hip goes into abduction and external rotation, not in adduction and internal rotation. Okay. So, if you do the ultrasound of that patient, that will show widening of the joint space. Okay. That is also true statement, but that is for as far as our question is concerned, this is not the answer. So, answer to the question number 139 is going to be C. The hip is typically held in adduction and internal rotation, which is a false statement. Hip should be in abduction and external rotation. So, question number 140, true about about TB spine, choose the incorrect statement, the wrong statement we are supposed to select. So, we all know dorsal spine is the most commonly involved site in the tuberculosis of the spine, in the port spine, and the organism spread to the spine through the hematogenous route. Okay. But if you see, the most common elements involved are the anterior elements or vertebral bodies. Okay. In vertebral bodies, the tuberculosis is mainly of paradiscal type, means it involves the area around the disc. Okay. So, this statement which says that it involves the posterior elements commonly, this is not true and should be the answer of this question. Next statement, they have said that long standing paraplegia carries poor prognosis. That is true if there is a pressure over the spinal cord or spinal nerves from long time, so their blood supply will be hampered and their recovery will not be that good. On the contrary, the short standing paraplegia has good prognosis. Okay. So, this statement is also correct. So, only incorrect statement in this question is the statement C, which says that it involves the posterior elements commonly. No, it does not involve the posterior elements commonly, it involves mostly the vertebral bodies and it is mainly paradiscal type of involvement, paradiscal. Okay. So, let us move on to next question. Pestle and mortar appearance of hip is seen in. Pestle and mortar appearance is also known as wandering acetabulum. Which is commonly seen in tuberculosis of the hip joint. Okay. Let us have a look at the next slide. If you see, tuberculosis of the hip can be divided into the 4 different stages. Stage 1 is stage of synovitis, when we will have flexion, abduction and external rotation deformity of the limb. Okay. And if you see on x-rays, you will see haziness and rarefaction. Okay. In stage 2 of early arthritis, again you will have flexion, adduction and internal rotation deformities, and on x-rays you will see rarefaction, osteopenia and bony lesions in the femoral head or acetabulum. Okay. And joint space is still preserved. In stage 3, stage of arthritis, we will have flexion, adduction and internal rotation deformity. So, there will be shortening, which indicates that joint space has been reduced. So, all these features will be there. So, destruction of the cartilage will lead to reduction in the joint space as well. In stage 4, which is called stage of advanced arthritis, we will have flexion, reduction and internal rotation deformities with gross shortening. There will be quite a lot of shortening. In Stage 3, there was shortening due to damage to the cartilage. Now we have more shortening in stage 4, that probably due to destruction of the femoral head. So complete destruction, no joint space, wandering acetabulum. And if you see radiologically, the head has been destroyed, the acetabulum has become bigger, and it appears like if we have a mortar in the pestle used for the grinding the things. Okay, so mortar in pestle appearance is seen in stage 4 of tuberculosis. This is again X-ray picture showing nicely the acetabulum. Okay, and this thing, the femoral head has been destroyed, the acetabulum is empty, and lot of space is there between these two things. So this is a mortar in pestle appearance, which is commonly seen in tuberculosis. Okay, so next question 142. Which of the following is not a cause of sudden increase in pain in osteochondroma? We all know osteochondroma is something which is a slowly growing growth deformity or aberrant growth due to the cartilage growing from the physis. Okay, so it usually have a bursa around that, so that can get inflamed, that will lead to bursitis, which is again it takes some times to develop, and patient will have immediate pain. Okay, and if the pedunculated osteochondroma fractures, that will lead to sudden increase in pain as well. Okay, so sarcomatous changes, malignant changes also will give rise to sudden increase in size and sudden increase in pain. Okay, degenerative changes which are not that common, but as we know all the degenerative arthritis, they usually are slowly developing, they take time to develop. Okay, so the osteochondroma degenerative changes will lead to slow increase in the size, it will lead to inflammation of the soft tissue around that due to degeneration, that will lead to formation of fluid in the bursa, and these changes will be slow. So the question 142 will have answer D, degenerative changes. So next question is 143. Which of the following is the commonest true benign tumor? So we all know enchondroma is a tumor of cartilage. They are asking true benign bone tumor. Okay, osteochondroma is not a tumor, basically it is a aberration of the growth. Where the part of the physis has separated during the growth period, and it has started developing into osteochondroma. So this is also not a true bone tumor. Okay, hemangiomas are malformations in the vessels inside the bones, and this is basically a hamartoma, and this is also not a tumor of the bone, this is basically related to the vascular tissues. Osteoid osteoma is the true primary bone tumor, which is small in size and has got a lytic lesion in the center and is surrounded by the sclerosis. Okay, so the osteostroma is the answer to the question, which is a true benign bone tumor. 143. The question number 144. Osteoclastoma, which is also known as GCT or giant cell tumor, is treated with all of the following except. Now the options given are joint replacement, excision, arthrodesis and chemotherapy. Okay, let us have a look at how basically GCT, we need to know the classification of GCT before we go into details of the treatment. Okay, so it can be graded into grade 1, which is called quiescent, or also we call it latent stage. Okay, here the margins are well defined of the tumor. Okay, cortex is thinned, but cortex is not breached. Okay, you can see the proper outline of this tumor. Okay, in grade 2 where the lesion is active, we still have well defined margins, but the cortex has thinned out and at some places it has become expanded as well. That is stage 2. In stage 3, which is called aggressive stage, okay, so there is a cortical breach, the cortex is broken, okay, and the tumor has migrated to the soft tissue. Okay. So, now if we have grade 1 and grade 2 tumor, usually we have different treatment options. If the tumor is grade 3, the treatment option is different. Okay. So, the treatment option of grade 1 and grade 2 are usually what we do, will take out this diseased area and we will fill it with the help of either bone graft or bone cement. Okay. Sometimes if lesion is expanding and going to the cortices and cortex have become thinned out, then what we can do is we can remove the diseased portion of the bone and we can fuse the joint by putting either nail or Elizaro, which is called arthrodesis of the joint. Okay. In some cases what we do is we take out this portion of the bone which is diseased, and mostly what we do is we put a prosthesis over that, which is called joint replacement. Okay. So, we can put a prosthesis over here and plastic in between, that is called joint replacement. And if we have stage 3 tumor which is quite aggressive, in those cases mainly you have to do en bloc excision and you can do arthrodesis or you can do joint replacement. Okay. So, but if you see, the chemotherapy has no role in the treatment of GCT. So, joint replacement, yes, can be done, excision of the part, yes, can be done if it is grade 3. Okay. Arthrodesis can be done both in grade 2 and 3. Joint replacement can be done in stage 2 or 3. Okay. But chemotherapy has no role in the treatment of GCT. So, the answer to this question is going to be D, the chemotherapy. The question number 145, all of the following investigations are needed for diagnosis of osteosarcoma, except, he is asking which investigation can be done and which investigation given out of these choices is not not required for osteosarcoma. MRI of the involved site, yes, should be done to know the extent, to know the compartment involved, to know the vessels involved or nerves involved, so that we can plan the definitive treatment. Bone marrow biopsy has nothing to do in this case. Yes, we can do the biopsy of the involved site of involved area, but doing bone marrow biopsy is not going to give us anything. Okay. So, this is going to be the answer, because bone marrow biopsy is not the investigation of choice. Yes, we can do biopsy of the involved area. Bone scan, yes, we want to do the bone scan to see whether there are any metastases to the other bones or not. Okay. We can do CT chest to find out any metastasis in the chest. So, the answer to this question should be bone marrow biopsy, which is not the choice of investigation in osteosarcoma. We usually do biopsy of the involved area. Okay. The question number 146, osteosclerotic metastasis is common in cancer of. Basically, they are trying to ask the metastasis of which carcinoma or cancer are osteosclerotic or osteoblastic. So, if you see the metastasis which arise due to the carcinoma of the prostate are usually osteoblastic. If you do an X-ray, you will see osteosclerotic lesions in prostate carcinoma. Why it happens? Because the prostate carcinoma cells secrete factors that are directly or indirectly responsible for osteoblastic function. Okay. They then enhance the osteoblastic activity and their function, and they also express factors for normal bone growth and development and remodeling. These factors which are expressed by the cells from the prostate carcinoma include bone morphogenic proteins, transforming growth factors, platelet derived growth factors, adrenomedullin, insulin like growth factor, fibroblast growth factors, and vascular endothelial growth factor. All these factors are responsible for bone growth and remodeling. So that's why the prostate carcinoma metastases are usually osteoblastic. So the answer to this question is prostate cancer has osteoblastic or osteosclerotic metastasis. Okay. So question number 147, major mineral of bone is, we all know the bone has got calcium and phosphate, but it usually occurs in the form of hydroxyapatite. Okay. So the answer to the question number 147 is going to be B, hydroxyapatite. Okay. Inorganic, so we all know bone has got organic plus inorganic component. Inorganic components are basically calcium and phosphate, which occurs mainly in the form of hydroxyapatite. So the answer to the question number 147 is going to be B. So question number 148, a 30-year-old biker sustained a compound fracture of the leg following a road traffic accident. The compound fracture, open fracture of the leg, okay, following road traffic accident, high energy injury. The doctor has labeled it Gustello-Anderson type 3. So this is open fracture which is classified according to the Gustello-Anderson classification, and this fracture was labeled as type 3B fracture. Which of the following would represent the injury? So if we see the Gustello-Anderson classification, we have three types: type 1, type 2, okay, and type 3 is further divided into type 3A, type 3B and type 3C. In type A, we have less than 1 centimeter wound, okay. There will be minimal contamination and fracture is going to be usually oblique or transverse, okay. There is no comminution of the fracture in type 1 Gustello-Anderson. In type 2 fractures will have 1 to 10 centimeter wound. There will be moderate soft tissue injury and moderate comminution of the bone, okay. In type 3 wounds, in type 3 and Gustello-Anderson classification, the wound is usually more than 10 centimeter. This is high energy injury and will involve lot of soft tissue damage, okay. There will be contamination of the wound and there will be comminution of the bone as well. But in type 3A fractures, in spite of having extensive soft tissue damage, it is possible to cover the wound with whatever soft tissue we are left with. But in type 3B fractures, the wound is it is not possible to cover the wound with whatever soft tissue is left. So we have to do some sort of flap surgery to cover the wound. So in 3B, there will be wound of more than 10 centimeter, okay, but the soft tissue coverage of the area will not be possible. We will definitely need some sort of a rotational flap or free flap, okay. In type 3C injury, no matter whatever the injury is, patient is going to have vascular injury. If patient has got vascular injury, you label it type 3C fracture regardless of what soft tissue injury is there. So the choice A they have given is fracture with open wound less than 1 centimeter. We have seen that they are type 1 injuries. Fracture with open wound 1 to 10 centimeter, but soft tissue cover possible. This is type 2 injuries. The wound is 1 to 10 centimeter. Open wound more than 10 centimeter, and soft tissue coverage not possible. We have just seen these are the type 3B injuries. In type 3A the coverage of the soft tissue is possible, but in 3B coverage is not possible. Okay, so the answer to this question is C. Open wound more than 10 centimeter wound with arterial injury. So, the patient has got arterial injury, so this is going to be type 3C injury. Okay, so the answer to the question number 148 is C. So, next question is, an engineering student age 26 presented to the emergency department with pain in the wrist post a fall on an outstretched hand from the motorcycle traveling at a speed, very high speed. So, he has got a fall on outstretched hand and he has got pain in the wrist. So, fall on outstretched hand, pain in the wrist could be anything. It could be distal radius fracture, it could be distal radial nerve joint dislocation or subluxation, it could be a Galeazzi fracture dislocation or fracture of any of the carpal bones like scaphoid. So, they have done some investigation, okay, which investigation reveals swelling, diffuse tenderness and deformity. Okay. Limited wrist movements, they all are features of a fracture or dislocation. Okay. And we can see a spilled teacup sign, on posterior anterior view of the X-rays of the wrist joint. What is the most probable diagnosis? Okay. So, if you see, you do not see any this kind of scene in scaphoid fracture or fracture of the radial styloid. Okay. So, the answer is either lunate dislocation or post traumatic arthritis is not going to have this kind of feature. So, answer to this question should be lunate dislocation. But what is spilled teacup sign? Let us have a look at this picture. Now, if you see, our distal radius articulates with lunate and lunate further articulates with the capitate. Okay. Now, if the lunate stays in place and capitate dislocates, this is called perilunate dislocation, and here the lunate is articulating with the lunate fossa of the radius, but it is not articulating with the capitate. So, this is called perilunate dislocation. Okay. Now, in another type of lunate dislocation, what happens, the lunate dislocates, it does not articulate either with the distal radius or with the capitate. So, the lunate has dislocated from its place and lying separately, and if you see on the X-ray, the dislocation of the lunate appears to be like spilled teacup sign, the tilted teacup which can easily spill the tea. So, that is why the spilled teacup sign is present in lunate dislocation. So, that is why the answer to this question is lunate dislocation, which is B in this case. Okay. So, the next question is question number 150. Which of the following movements will be affected if greater tuberosity of the humerus is fractured? Okay. So, to know the answer to this question, we must know what is attached to the greater tuberosity, because if that thing is fractured, the muscle attached to that will not be able to do any movements. Okay. So, those movements will be affected. So, if you see this picture, this is the lesser tuberosity of the humerus and this is the greater tuberosity. On greater tuberosity sits over greater tuberosity, which means supraspinatus, infraspinatus and teres minor. On lesser tuberosity is attached subscapularis. Okay. So, if greater tuberosity is avulsed, this supraspinatus, infraspinatus and teres minor will be avulsed. So, whatever movements they are causing will not happen at the shoulder joint. So, we all know supraspinatus is responsible for causing abduction of the shoulder. Infraspinatus and teres minor are responsible for causing external rotation of the shoulder. So, if the greater tuberosity is avulsed, these movements will not be there. So, abduction and external rotation will be lost. Internal rotation will be preserved because lesser tuberosity is at its place. So, if we see the answers, answer A says abduction and external rotation will be lost. So, yes, we have seen on greater tuberosity are attached supraspinatus, infraspinatus, and teres minor. If that is fractured, so these movements will be lost. Adduction will not be lost, flexion will not be lost, all these movements will not be lost, only abduction and external rotation will be lost. So, A is the answer to question number 150. So, that is all from this session. Rest of the question we will do in the next session. Thank you.